So current treatment for neovascular or wet macular degeneration is pharmacologic primarily. The focus of the treatment is to stabilize or inhibit the leakage from neovascular membranes, aberrant blood vessels growing within and underneath the retina that could cause damage to macular cells. And so previously, prior to the pharmacologic treatments we have today, we used to use laser treatments to cauterize those vessels. We found those treatments to be effective, but disruptive with secondary damage to the macular tissue. And they had unwanted side effects of vision loss, ironically associated with them. And so these pharmacologic treatments are focused on stabilizing these blood vessels with an antibody approach or antibody fragment approach. These are biologics that we inject into the eye, and these biologics inhibit a variety of vascular growth factors, specifically a family of growth factors related to vasculature called vascular endothelial growth factor. There are three subtypes, major subtypes that these drugs inhibit, and currently we have 4 medicines on the market meant to slow the growth and leakage from these vessels. Now, when it comes to individualizing treatment for each patient, we use a paradigm called treat and extend. That's most commonly used in the vitreoretinal world. And treat and extend is a paradigm in which a patient is treated with an intraocular injection after being numbed and prepared with antibiotics. And the injection delivers these antibodies, these biologic medicines directly to the retina in the vitreous cavity. And we start with monthly injections. So about every 4 to 5 weeks, a treatment. And we watch the patient's exam, imaging, and vision, looking for improvement over time. As we start to normalize the anatomy and improve the vision, we then try to extend the time between the injections by a certain interval, usually by 2 weeks. And the longer and longer we go, for some patients, we'll find that, well, we've gone too long and they've gotten some recurrent vision loss because the effect of the medicine has worn off. And so we tighten up the interval. On average, patients will make it every 6 or 8 weeks between treatments without having a recurrence or drop in vision. And there are some patients that we find that need to be treated every 4 weeks, while others can get away, I should say, with being treated every 12 weeks. It's very individualized care. And that way, we're not under-treating, we're not over-treating. We're trying to achieve what I call the Goldilocks effect, not too hot, not too cold for each patient. I think this really balances the need for efficacy with safety and treatment burden. So it's a great technique that most retina specialists use.